In this lecture, we'll look at the global burden of disease. A country's burden of disease refers to the assessment of mortality, morbidity, injuries, disabilities, and other risk factors specific to that country. Quantifying the disease burden in a way that's internationally comparable is not always an easy task. A specific method of quantification was, however, standardized by the seminal international study in this field, the Global Burden of Disease Study, which introduced a metric for measuring the burden of disease in an area. This is called the Disability Adjusted Life Years, also known as DALYs. The Disability Adjusted Life Years, or DALY, is an incidence-based measure quantifying the health gap between a population's actual health status and a specified norm. It measures the future stream of healthy life years lost due to each incident case of disease or injury by adding together the years of life lost, YLLs, due to premature mortality and years of life lived with the disability, YLDs, weighted according to the severity of the disability. A disability weight is a weight factor that reflects the severity of the disease on a scale from 0, perfect health, to 1, which is equivalent to death. The years of life lost due to disability, YLD, are calculated by multiplying the incident cases by duration and disability weight for the condition. A country's burden of disease can be divided into 4 groups. Each group is considered to be one burden. So a country with a quadruple burden of disease is grappling with all 4 groups. Group 1 includes all pre-transitional causes. That means communicable diseases, maternal and perinatal conditions, as well as nutritional deficiencies. These causes of death are usually highly correlated with underdevelopment and poverty. Group 2 includes all non-communicable diseases or chronic illnesses, such as cardiovascular disease, stroke, cancers, or diabetes. Group 3 represents injuries. Group 4 represents the heavy burden of HIV and AIDS. This last group emerged from the experience of South Africa. In this chart, you can see that the countries have been divided into 2 economic groups, developing countries and developed countries. You can see that the developing countries on the left are struggling to cope with either a triple or quadruple burden of disease. While Tunisia grapples with a triple burden of disease, the other countries are struggling with a quadruple burden, especially due to HIV and AIDS. While non-communicable diseases or chronic diseases are a majority of their cases, there are high numbers of other communicable, maternal, perinatal, or nutrition-based illnesses, as well as injuries. The developed countries all have to cope with the triple burden of disease, but you can see that the majority of the cases are non-communicable, with a small number of other communicable diseases, maternal, perinatal, and nutrition and injuries. In this graph, you can see the disability-adjusted life years per 100,000 population. There's a stark difference between the DALYs of South Africa compared with developed countries. And you can appreciate the burden of disease on the developing countries in the graph at the right compared with each other. While it's quite popular to focus attention on the leading causes of death, it's even more important from a health system and public health perspective to focus on the related risk factors or actual causes of death. While heart disease, cancer, and stroke are among the top 3 leading causes of death in the United States in 2000, you can see that the actual cause or underlying factors which contribute to these deaths include tobacco use, poor diet, physical inactivity, and alcohol consumption. The economic, social, cultural, political, environmental, and other factors of a country are constantly changing. Sometimes countries improve to such an extent that they are moving from being classified as a developing country towards being classified as a developed country. And even with countries, there are shifting geographic regions which move from developing communities to developed communities. As these economic and other factors shift, there's a strong impact on the health of these countries. The impact of these changes on health including the incidence of disease and the health system's ability to respond, is called an epidemiological transition. Epidemiologic transitions focus on the complex change in patterns of health and disease and on the interactions between these patterns and their demographic, economic, and sociologic determinants and consequences. Abdel Amran, in 1971, wrote The Epidemiologic Transition, a theory of the epidemiology of population change. He characterized these transitions into three categories. The age of pestilence and famine, in which the average life expectancy is low and variable between 20 and 40 years. Second, the age of receding pandemics, where mortality declines progressively. The rate of decline accelerates as the epidemic peaks become less frequent. The average life expectancy increases from 30 to 50 years, and now population growth is sustained and begins its exponential curve. Third, the age of delayed degenerative diseases. Life conditions that were previously conducive to the spread of infectious and parasitic diseases are rapidly replaced by more sanitary living conditions, improved medical technology, and better lifestyles. As the risk of dying from infectious diseases is reduced for a population, those saved from dying from such diseases survive into middle and older ages, where they face the elevated risk of dying from degenerative or man-made diseases. There's a new addition to the third epidemiological transition. The recent resurgence of infectious disease mortality marks a third epidemiologic transition, and this is characterized by newly emerging, re-emerging, and antibiotic-resistant pathogens in the context of an accelerated globalization of human disease ecologies. Some recent examples include the Ebola outbreak, an increase of methicillin-resistant Staphylococcus aureus, or MRSA, and a resurgence of tuberculosis, especially multiple drug-resistant tuberculosis. These transitions illustrate recurring socio-historical and ecological themes in human disease relationships, from Paleolithic age to the present day. The impact of these epidemiologic transitions can be seen very dramatically by looking at the distribution of mortality statistics by age among developing countries. Just look at the top section of infant mortality rates for children from 0 to 4 years of age. From 1960 to 1965, the mortality rate was 45.45%. By 2010 to 2015, the death rate for this population group was reduced to 18.62% of the population, and the percentage of total deaths by the older population above 65 years of age increased from 16.76% of the population in 1960 to 65 to 46.88% of the population by 2010 to 2015. These figures demonstrate that there is a shift towards the age of delayed degenerative diseases. Looking at the Africa region, however, these figures demonstrate that these population groups are still moving towards the third phase. These categories of epidemiological transitions can also be seen in the analysis of death rate by broad causes. Although in every region there's been a significant shift lowering the numbers of people who die from communicable diseases, maternal, neonatal, and nutritional conditions, as well as an increase in the numbers of people who die from non-communicable diseases, the African region still suffers from a very high percentage of people who die from communicable diseases. Many of the diseases we face are directly related to conditions of poverty. These diseases of poverty are typically acute ailments that are caused by poor nutrition, degraded environmental conditions, and lack of access to care. As we've just seen, infant and child mortality rates have been decreasing steadily since the 1950s. Mortality rates are linked to birth order, economic conditions, ethnicity, maternal age and education, and gender. There's a strong correlation between maternal health, prenatal care, and survival rates among newborns. In anthropology, it's long been recognized that there's a relationship between birth rates and health status that are related to economic and social stability. For families with high child mortality rates, there are usually large numbers of children, from 6 to 8. Children, besides being seen as a blessing from God, are also viewed as the support for the parents in their older age. With high child mortality rates, families need 6 to 8 children to ensure that at least 2 survive to care for their parents. When the health and economic and social conditions improve and infant mortality rates decrease, so does family size, without any need for forced population control programs. Food safety is another major contributing factor to diseases of poverty. Food contamination includes foodborne diseases, including those caused by parasites such as tapeworms. Nutrition is the science of food, nutrients, and their biological components, the action, interaction, and balance in relation to health and disease, and the process by which organisms absorb, digest, transport, utilize, and excrete food substances. Malnutrition is poor health status that's due to long-standing dietary practices that do not coincide with nutritional needs, and includes both undernutrition and overnutrition. Approximately 35% of all deaths under the age of 5 are associated with malnutrition. Another 27% of children under age 5 are underweight, increasing their risk of developing infectious diseases. Malnourishment as a child increases risk in adulthood for cardiovascular disease, high blood pressure, diabetes, renal disease, and high cholesterol. Some examples of malnutrition include protein energy malnutrition, which is a nutritional deficiency caused by insufficient food intake and infectious disease. This nutritional state is closely related to insufficient knowledge, poor sanitation, poverty, and lack of access to care. Micronutrient malnutrition includes insufficient dietary intake of iodine, iron, and vitamin A. Obesity is also a form of malnutrition, which is often caused by genetic factors, stress, trauma, and increasingly leads to diabetes and cardiovascular diseases. Acute respiratory infection is a leading cause of death for all age groups. This can be due to low birth weight, poor nutrition, low income, indoor air pollution, which are among individual and environmental factors that heighten risk. Acute respiratory infection can also be caused by infectious causal agents like measles or pneumonia, or ambient air pollutants like sulfur dioxide or coal ash. Frequently, people who cook with kerosene, charcoal, or even cow dung inside their closed homes are particularly susceptible to respiratory infections, such as tuberculosis, pneumonia, and allergies. Diarrheal disease is the second leading cause of killing children under the age of 5. There are a wide variety of causes, but most often a pathogen in contaminated water, such as cholera or shigellosis. Hand washing reduces the incidence of diarrheal disease by 40%. One of the most effective treatments for diarrheal disease is oral rehydration therapy. This is a very simple and inexpensive treatment that replaces lost fluids orally rather than intravenously and counteracts the dehydration effect of the diarrhea regardless of the causal agent. 6 level teaspoons of sugar plus 1/2 level teaspoon of salt dissolved in 1 liter of water is a very effective therapy to maintain fluids and electrolyte levels. Adult illness and poverty. Some of these same causal factors apply to adult illness. These include lack of safe drinking water, lack of food safety, poor sanitation, poor housing, malnutrition, chronic parasitic infections, and lack of curative measures. Common adult illness in developing and impoverished nations include diarrheal disease, tuberculosis, malaria, venereal disease, respiratory disease, maternal illness, HIV and AIDS. Although health is a very personal status, an individual's health can be seen as a shared responsibility because it affects and is affected by other aspects of a socio-ecological system. This system centers on the individual and is related to and connected by family, friends, schools, community, and other social, cultural, political, and environmental factors. These factors are also known as the social determinants of disease and must be addressed as part of any health system. Going back to the 19th century, physician, epidemiologist, and social scientist Dr. Rudolf Virchow was convinced that many of the diseases plaguing people in the cities were due to these environmental, social, and biological factors, including poor sanitation, sewage-contaminated water, overcrowding, and poor nutrition, including food safety. Although most medical care became increasingly focused on treatments such as vaccines, antibiotics, and surgery, these socio-ecological factors have become recognized as important parts of health care. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. The Rio Political Declaration was endorsed by the World Health Organization member states at the 65th World Health Assembly in Geneva, Switzerland in May 2012, and called upon the World Health Organization to act in 5 areas: to adopt improved governance for health and development, to promote participation in policy making and implementation, to further reorient the health sector towards promoting health and reducing health inequities, to strengthen global governance and collaboration, and to monitor progress and increasing accountability. Many health systems address these social determinants in their approach to health care. In South Africa, for example, access to health care is a constitutionally defined right, and as part of the government's approach to health, they include the need to address social determinants. For example, their approach to tuberculosis control includes initiatives in housing, education, occupational health, as well as strengthening diagnostic treatment and other systems of care.